Medications. Psychotropic means mind moving or mind changing. So we're going to talk about, first thing we're going to talk about are antidepressants. So let's go ahead and get started. I just looked all this up to see if there's any new medications out there. Most of the medications are either combinations of what I'm going to talk about today, or just a change in how you deliver those medications. I was looking at antidepressants. They were talking about a spray that you spray up your nose, but it's the same stuff that we've been using for years. They have mixed, they've put two medications together, dextromethorphan and bupropion, which are both, one is a for cough, is in cough syrup, dextromethorphan is in cough syrup, and bupropion is an antidepressant. But so they have put them together. It's a new antidepressant, but we won't be dealing with that. SSRI antidepressants, the mechanism of action for SSRIs. SSRIs inhibit serotonin reuptake so that they increase synaptic serotonin levels. Very logical. Many SSRIs affect other receptors, especially at high doses. SSRI's clinical effect usually takes weeks, so the mechanism goes beyond simply increasing synaptic serotonin levels. There are several serotonin receptor subtypes, and we're going to talk about serotonin receptor subtypes, serotonin receptors as 5-HTs. That is the chemical indication of serotonin. Serotonin receptors are located throughout the body, especially in your GI tract, so they're in your gut. All SSRIs except Luvox are FDA approved to treat depression, major depressive disorder, and dysthymia. Dysthymia is the old term for low-level blues or high-level blues. Of course, depressive disorder is very specific, and it tends to be very intense. If it's just low-grade depression, they used to call it dysthymia. They have done away with that term now. Various class members of SSRIs are also approved to treat generalized anxiety disorder, OCD, panic disorder, PTSD, eating disorders, premenstrual dysphoric disorder, and social anxiety disorder. And I just looked up anxiety medications, and the new medications for anxiety are all antidepressants. So, and they're actually nothing new. They're the old antidepressants in a new configuration. Off-label use of antidepressant or SSRIs, ADHD, insomnia, chronic pain syndromes, seasonal affective disorder, behavioral problems in individuals with dementia, and an intellectual disability. The half-life, short half-life, missed doses can result in uncomfortable symptoms. The drugs that have a short half-life are Paxil and Luvox. Those that have a moderate half-life are Zoloft, Celexa, and Lexapro. And the SSRIs that have a long half-life are Prozac. And of course, you need to be really careful if you're taking an SSRI with a short half-life, because if you miss a dose, then you'll start having symptoms, not of depression. You'll actually get you'll get sick. You'll start vomiting and whatnot. And same for the moderate, and of course the long term are good for people that tend to miss doses. Side effects of SSRI antidepressants: decreased sex drive and impaired sexual function tend not to be resolved with time, and this is something that you need to remember. So if somebody goes on an antidepressant, the probability of them getting the sex drive that they had prior to taking the SSRI is not very high. Usually it doesn't happen. And as a matter of fact, some SSRIs, some people, the side effect of SSRIs is that they have what they call emotional blunting, where they feel they don't have as much affection for individuals and for things as they did before. Nausea, diarrhea, anorexia, vomiting all increase with dose and can be resolved with time. Weight gain, especially Paxil, also known as paroxetine, after initial GI effects, weight gain, headache, dizziness, anxiety, especially Prozac, another name for Prozac is fluoxetine, rash, insomnia, sedation, sweating, vivid dreams, tremor, dry mouth, especially with Paxil, paroxetine, bruising, increased prolactin, protein that enables females to produce milk. Drug interactions, Luvox increases Prozac, increases Paxil, increases Zoloft, increases Celexa, increases Lexapro. So if you're taking any of those SSRIs uh, and they give you another SSRI to take, it will increase it exponentially. The interacting of, and of course, most physicians will not give you two different types of SSRIs. Um, so it's it behooves you to tell your doctor what you're taking. The interacting effects may be dose dependent, especially with Zoloft. SSRI levels tend not to be altered by other drugs, but can potentially increase levels and inhibit their metabolism of other drugs. And of course, doctors know these drug interactions, and your pharmacist knows these drug interactions. Examples, Paxil increases risperidone. Risperidone is, of course, an antipsychotic. And I was looking up schizophrenia. Schizophrenia, there is a new medication, but it is just another type of risperidone. Prozac increases buspirone, which is an anxiolytic and anti-anxiety drug. And Luvox increases olanzapine, which is an antipsychotic. Suicidal cautions of taking SSRIs, and this is something we've known with Prozac for an extended length of time. Suicidal ideation and increased suicide risk, especially with children early in treatment, but there is significant debate about that. This is one of the reasons why we don't give SSRIs to adolescents, because it increases the possibility of suicidal ideations. Of course, we do. There are situations where adolescents are administered antidepressants, but there's a very close monitoring of what's going on. Serotonin syndrome, SSRIs plus MAOIs, possibly lithium and others, causes diarrhea, tremor, sweating, restlessness, hyperreflexia, leads to a progression of symptoms if untreated. And this is really important. This is one of the reasons why you should never keep a medication that you're taking from your physician. If you're taking an SSRI, don't ever take an MAOI because you can have this serotonin syndrome. If it goes untreated, disorientation, rigidity, fever leads to coma, seizures leads to death, and approximately it has a 10% mortality rate. So the probability of of dying from serotonin syndrome is very high. It's 10%, one out of every 10 people that come down with serotonin syndrome. And usually what happens is it's very noticeable, and the doctor gets the individual off of the MAOIs almost instantaneously. And that's why the death rate is so low, because normally this is caught very quickly. If it's someone that isn't communicating with their doctor, and they're just kind of sitting there, and they're taking the two medications, these are the people that die, the ones that aren't being monitored very closely by their doctor. Many medications, substances have serotonin activity. Dextromethorphan, which is a cough medicine, and I mentioned that that is one of the new antidepressants, dextromethorphan and bupropion. Fentanyl is an opioid, and it will have serotonin activity as well. Meperidine, it's an opioid commonly called Demerol. It has serotonin activity. Somatriptan, it's a migraine headache medication. It has serotonin activity. St. John's wort, it's an herbal antidepressant. As a matter of fact, it's very popular in Europe. MDMA, ecstasy, of course, LSD. All of these have a lot of serotonin activity, which leads to, hey, look, if you're taking if you're taking an antidepressant, don't drop ecstasy. I mean, that doesn't make any sense. It's going to increase your serotonin level, and it's also going to make your brain less sensitive to serotonin. So what you're going to have is a downregulation of serotonin. Not a really good idea. Not something that you want to see. Same thing with LSD. It increases the serotonin level. You're going to have a downregulation of serotonin in your system. And of course, it's going to be more and more difficult for the antidepressant to work. Celexa, citalopram, it has few drug interactions. It has high serotonin specificity. It's typical or less selective serotonin side effects. Celexa. Lexapro, there's no generic available. It is simple dosing. My wife was taking Lexapro for a while. Fluoxetine, also known as Prozac, Serafim, Symbyax with Zyprexa. Very long half-life, as we already found out, has significant drug-to-drug interactions, and you need to be very, very careful if you're taking Prozac and taking any other medication at the same time. Luvox, OCD indication. So Luvox is a common medication given for OCD. Multiple significant drug-to-drug interactions, so you have to be really careful with Luvox as to what medications you're taking. Paroxetine, also known as Paxil. Significant drug-to-drug interactions. Some reports of associated weight gain with Paxil. Withdrawal symptoms with missed doses. So be careful. Zoloft, moderate drug-to-drug interaction, multi-step dosing is normally the way Zoloft works. The newer antidepressants that are not or less serotonin specific or affect serotonin differently than SSRIs. 1981, Desiril came out, also known as Trazodone. They were using it to treat people with PTSD, especially Vietnam vets were taking Trazodone. 1989, Wellbutrin came out, bupropion. It doesn't have as many side effects, and it doesn't have any sexual side effects. 1993, Effexor, venlafaxine. 1994, Sarazone, Nefazodone. 1996, Remeron, mirtazapine. 2004, Sarazone discontinued, although generics still available, especially in Europe. 2004, duloxetine, also known as Cymbalta. And you may have seen Cymbalta advertisements on television. They say if your antidepressant's not working, here, pair it up with Cymbalta. Mechanism of action, Effexor and Cymbalta are both serotonin and norepinephrine reuptake inhibitors, or SNRIs. Remeron has serotonin subtype and norepinephrine activity. Trazodone and nefazodone have different serotonin activity than SSRIs. One of the reasons that trazodone was given to people with PTSD is because it makes you skip over the first level, the uh, delta wave sleep. It makes you skip over it, and that's where they were having their intrusive dreams, and that, of course, what they were doing, they were getting drunk, and then and the alcohol was allowing them to not have those intrusive dreams. Trazodone kind of did the same thing. The problem with trazodone, it made them um, tired throughout the day. That was the problem. Bupropion has dopamine and norepinephrine activity. Um, all typical and atypical antidepressants have FDA approval to treat depression. SNRIs have been shown to be effective in chronic neuropathic pain, while Butrin has been approved to treat nicotine addiction. While Butrin can augment SSRIs to reduce SSRI sexual side effects, Wellbutrin and bupropion. Remeron and trazodone are used to treat insomnia. Both atypical antidepressants have many similar uses to typical SSRIs, while Butrin, Remeron, trazodone, and nefazodone do not usually have associated sexual dysfunction. Effexor is similar to tricyclics with less safety and side effect concerns. Effexor has FDA approval for depression and generalized anxiety disorder and social anxiety disorder. As an SNRI, Effexor activity depends on the dose. Effexor has a minimal drug-to-drug interactions. Effexor has side effects with missed doses, as my wife found out when she forgot her Effexor when she went away. She went to a conference, and luckily the lady that she was rooming with was also on Effexor. She started taking it because of menopause. That was one of the drugs, one of the medications that they gave her for her, for her menopause symptoms. Cymbalta is an SNRI that has minimal dose dependency. Cymbalta is indicated for depression and chronic neuropathic pain. Bupropion, Wellbutrin, Zyban. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Zyban is used to treat smoking addiction. Bupropion is a seizure risk in certain patients, increased risk at high doses. Bupropion's drug-to-drug interactions are not often significant, except with MAOIs. And one of the things we're going to find out is that if you're taking an MAOI, don't take anything else. Mirtazapine, and I'm laughing about it, but the reality is that MAOIs work for people that are not reacting to other antidepressants, but sometimes people are taking other medications that increase the serotonin level, and if that is the case, then the MAOI is going to have a negative effect on what's going on. Mirtazapine or Remeron, mirtazapine is a complex serotonin that has norepinephrine, alpha-2, and histamine activity. Mirtazapine has receptor activity changes with changes in dose. Mirtazapine has sedation and weight gain, especially at lower dose. Mirtazapine usage can have lipid abnormalities. Remeron has minimal drug-to-drug interactions, except, of course, with MAOIs. Nefazodone, nefazodone is rarely used due to irreversible liver toxicity. And this is one of the problems with just about all the medications you're taking. These are toxins, and that's the reason that they work. And it's the job of your liver to get rid of all these things. So if you're taking any medication, any of these medications, and you're drinking alcohol at the same time, not a really good idea because alcohol is destructive to your liver, but these things are too. And if you pair them up, then you're going to have more liver damage, and that's not a good idea. It's just not a good idea. If you have a sensitive liver, then potentially this could really cause a lot of destruction. So you need to be really careful as to what medications you're taking. And this is one of the reasons why when doctors start to give you medication, they want to know if you're drinking alcohol or if you're drinking heavily. If you're drinking heavily, there's not a lot of medications that you can take that aren't going to damage your liver more, especially acetaminophen. Acetaminophen, what's the common name for acetaminophen? Acetaminophen is a NSAID, and it's really hard on your liver. So if you're drinking and taking acetaminophen, not a really good idea. You're kind of really damaging your liver. As you get older, your liver naturally is not as functional as it was before, and this is one of the reasons that some people age really fast because they're taking too many medications. They're taking acetaminophen for muscle pains, and of course their liver can't get rid of that toxin as well as they could before. So you need to be really careful. I mean, you can really damage yourself just by taking the medications that you're told to take. But you need to tell your doctor what you're taking and explain to them if you're doing something like if you're smoking tobacco, if you're smoking marijuana. There was a new study that came out this week about pregnant women and marijuana. They're saying that the marijuana smoke is transferred to the child, and it's rearranging their brains. We've always known that marijuana did that, but now, of course, they've discovered that children are being there or unborn infants are being affected. So these are all things that doctors need to know if you're smoking tobacco, you're smoking marijuana, you're taking any street drugs, opioids, or drinking alcohol. These can affect the medications that you're taking, and the doctor needs to know that. Okay, so nifazodone was pulled from the market by initial manufacturer in 2004, although it is still available as a generic, especially in Europe. Nifazodone is still popular with some patients, and this is one of the things. If you're going overseas and you're seeing a local doctor, then some of the things that are blocked in the United States or the knowledge base in the United States totally different than it is in Europe. If you go overseas, then potentially they're going to give you something that might hurt you. Deseril, trazodone causes sedation, weight gain, low blood pressure. Trazodone is used most commonly off-label for insomnia. Rare reports of sustained painful erection, priapism, that should be treated in the emergency room. It can lead to impotence. It has been reported with trazodone, priapism. Tricyclic antidepressants describe a group of drugs with similar structure and function, and it's abbreviated as TCAs. Imipramine failed in 1958. Imipramine failed investigation as an antipsychotic, but it was found to have antidepressant properties. And this is the tricyclics are the first antidepressants. 1960s, multiple other TCAs, tricyclics, developed and were placed into use. And this is the first antidepressant that I came in contact with when I was in the service. We had to draw they are very destructive to, not very destructive, that's not really very fair. They can be destructive to the liver. So if someone is taking a tricyclic, then every 6 months, every year, you need to get a liver panel drawn to find out how your liver's doing. 1990, significant reduction in use due to introduction of SSRIs, which have fewer side effects. So through most of my medical career, there were no SSRIs. I can remember when Prozac came out in the 1980s, 1990s, late 80s, early 90s. This was after AIDS. AIDS came out. AIDS occurred, really hit the streets in the early 80s, 82, 83. But the SSRIs weren't developed until the late 80s. So people who were depressed were either not doing anything about it, or they were taking tricyclics, or they were taking MAOIs. The mechanism of tricyclic antidepressant action, there is norepinephrine, serotonin, histamine, muscarinic, which is a cholinergic, and alpha adrenergic receptor activity in differing ratios, and that's why tricyclics work. Anti-cholinergic activity leads to many of the side effects of these drugs. It is used for depression and similar spectrum of disorders as selective serotonin reuptake inhibitors. Tricyclics are especially helpful with chronic pain and depression secondary to medical conditions such as AIDS. And as I said, AIDS hit the streets in the early 80s, and tricyclics were the thing at the time. They were the antidepressants that we were using. Side effects include enuresis, narcolepsy, premature ejaculation, insomnia, migraine, prophylaxis. Prophylaxis means something that you take to keep you from having that problem. Prophylaxis. Blood may be obtained to monitor dose effectiveness, and that's one of the reasons that I came in contact with the tricyclic antidepressants. Drug-to-drug interactions for tricyclic antidepressants. Tricyclics have multiple significant interactions in each direction with potential serious consequences. Side effects of tricyclics for anticholinergic problems include dry mouth, constipation, blurred vision, and urinary retention. Cardiac arrhythmias and conduction changes, orthostatic hypotension, sedation, and weight gain. And that was the biggest complaint about the tricyclics, was the fact that people were gaining weight with it. Cautions when taking tricyclic antidepressants. Overdose is frequently fatal, and that's one of the reasons that we were drawing blood, was to monitor the level in their blood. Patients with bipolar disorder may be pushed into mania or rapid cycling. Amitriptyline, Elavil, is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and high in pain control. So amitriptyline was one of the drugs given for pain control. Amitriptyline is used, and of course, this is after the AIDS epidemic hit the streets. Amitriptyline is used to manage major depressive disorders, anxiety disorders, migraine headaches, and neuropathic pain. Amoxapine ascendin is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects, and it's low in pain control. Amoxapine works as an antidepressant rapidly, which is a good thing, of course. So if you've got somebody that's really depressed and you need to get them not depressed as quickly as you can, amoxapine is one of the drugs you could give them. One of the problems with the SSRIs, and something that we didn't talk about before when we were talking about the SSRIs, it takes 4 to 6 weeks for a therapeutic level to be built up in a person's system. Has been used as an antipsychotic. Amoxapine, clomipramine, nafranil is low in norepinephrine activity, high in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and it's high in pain control. It's used to treat OCD, depressive disorder, panic attacks, and anxiety. Dicipramine, norpinephrine, is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects. It blocks acetylcholine, and it's low in pain control. Dicipramine is used as an antidepressant and to treat ADHD. Doxepin, Sinequan, is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects. It blocks acetylcholine, and it's low in pain control. Doxepin is used to treat major depressive disorder, anxiety disorders, chronic hives, and insomnia. Imipramine, tofranil, is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects. It blocks acetylcholine, and it's moderate in pain control. It's used to treat depression, anxiety, and panic disorders, and enuresis. Lutamil is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects and moderate in pain control. Meproptyline is used to treat depression, anxiety, panic disorder, and neuropathic pain. Here's one you probably have heard of, nortriptyline. Pamelor is moderate in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects, and it is moderate in pain control. Nortriptyline is used to treat depression, anxiety, ADHD, neuropathic pain, and to help in smoking cessation. Vivactyl, protriptyline, is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Protriptyline is used to treat depression, ADHD, and its energizing effect is used to treat narcolepsy. Trimipramine, Sermontil, is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects and high in pain control. Trimipramine is used to treat depression, anxiety disorder, psychosis, and insomnia. Okay, so why in the world are there so many tricyclic antidepressants? Well, you got to remember that this was the only game in town there for a while. You had a choice between tricyclics and MAOIs. MAOIs have a lot of side effects. So most people who were having problems with depression, remember, this stuff was invented in 1958. So, and we didn't find SSRIs until the late 1980s, and it didn't really hit the market until the 1990s. So for 30 years, this was the only game in town, and I'm not sure how long you get when you invent something. When you get a new drug, it takes about you only get to have a you can only be the only game in town for a while, for about 10 years, and that's one of the reasons why there are so many. It's a lot of different pharmaceutical companies. As soon as they could start making tricyclics, started making tricyclics. It became a lot less expensive. Anyway, okay, so that's why there's so many tricyclic antidepressants. Now, we're not going to see the same thing with MAOIs because they have too much, there's too much side effect, too many side effects. But tricyclics were what people went to with depression until the SSRIs, and now the SSRIs have taken over the market. Monoamine oxidase inhibitors, abbreviated as MAOIs, they were invented in 1952, and they were the first game in town. But there's a problem. So let's talk about MAOIs. 1952, they were found as an antidepressant. They were looking for an anti-tuberculosis drug, but instead they found an antidepressant. 1962, investigation of a death from hypersensitive crisis for someone ingesting tyramine-rich food while taking an MAOI. So for 8 years, they were trying to figure out how the MAOIs worked. It was working as an antidepressant, and then people started dying in the 1960s. Institution of strict dietary restrictions of tyramine-containing foods, and we're going to talk about the tyramine-containing foods that caused the problem. 1960s, significant reduction in use due to introduction of tricyclic antidepressants, which do not have severe restrictions of MAOIs. In 2006, a transdermal selagelene patch, MSAM, was developed using MAOIs. So if you use this patch, you can't take any other antidepressants because there's going to be a negative reaction. So that's one of the things that they tell you. If you're taking an MAOI, do not take this drug. You can see them on television. They talk about it all the time. The features of MAOIs. MAOIs are an effective antidepressant for those who can adhere to the necessary restrictions and tolerate many of the other side effects. There are lots of problems with MAOIs. Very long duration requiring caution when mixing with restricted substances or medications. So you have to be really careful what you're dealing with. Tyramine-containing foods, not a complete list. This is not a complete list, but it includes a lot of stuff. Certain tyramines may be consumed in moderation. You can't eat cheese. You can't consume chocolate, soybeans, hot dogs. Anything that's any processed foods probably have tyramines in it. Dry sausage, you can't consume any caffeines. That's tea and coffee and all soda pops. Beer, wine, pickles, olives, anything that's fermented, you can't use it. Anything that's processed, you can't take it. So you can only eat fresh fruits, and that's just about it, and fresh meat. And you can't put anything on it except salt and pepper. Drug-to-drug interactions with MAOIs, multiple prescribed and over-the-counter medications can be potentially lethal. Serotonin syndrome with SSRIs and many others. And, this is a really serious problem, especially for males who don't like to talk about whether they're sick or not. If they're taking an MAOI and they start feeling bad, you got to go to the doctor right away. If you don't go to the emergency room, this serotonin syndrome is going to kick in and you get problems. Okay, so you can't eat any of the good stuff, pickles and olives. My goodness gracious. No cheeses, no soybeans. Available formulations of monoamine oxidase inhibitors, Nardil, Marplan, and Parnate. Aldapril is a fourth one. So we saw all those tricyclics, hardly any MAOIs, and the reason is because of the multiple side effects and the danger of taking this stuff. Selagelene is used to treat Parkinson's symptoms. It's a selective B inhibitor at low doses, so it restricts. Its restrictions are not as critical as Nardil, Marplan, and Parnate. At higher doses, it acts like typical MAOI, and so there's a need for restrictions at higher doses. Recently available as a transdermal patch, MSAM, to treat depression and not needing food restrictions at low doses, although still drug interactions, especially with SSRIs. Reversible selective A inhibitors not available in the United States, of course, once again. Okay, so now we're going to talk about mood stabilizers. This has to do with bipolar disorder. Mood stabilizers are used to treat bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes. aggression, impulsivity, augmentation of antidepressants and antipsychotics. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers. Mood stabilizers are used in the treatment of acute mania versus prophylaxis versus depression. So you take mood stabilizers so you won't go into mania and you won't go into depression. Okay, so the first mood stabilizer they discovered was lithium. But these other mood stabilizers are anti-seizure medications. Carbamazepine and valproic acid are both anti-seizure medications. So in 1949, they discovered that lithium was an anti-manic drug, so they used it for mania. 1949, lithium toxicity identified after being used as a substitute for sodium and salt. The idea was you could make sodium sulfate, I'm sorry, sodium chloride is salt. So what they did is sodium is a heavy metal, and chloride, of course, that's the combination. But they started putting lithium chloride, using lithium chloride instead of sodium chloride, and they thought, hey, we can just keep everybody from being crazy. Nope, didn't work. Lithium builds up in your system. Sodium builds up in your system, but you don't have as difficult a time flushing it out of your system. In 1966, French researchers demonstrate valproate's efficacy in treating mania. 1966. So valproate, which is an anti-seizure medication, or valproic acid, was discovered in 1966. So until 1966, the only treatment for bipolar disorder was lithium. Lithium is a heavy metal. It does build up in your system. I came in contact with lithium when I was working in the laboratory because we had to draw lithium levels on people with bipolar disorder who were taking the lithium to control their manic episodes. And of course, we needed to determine if they had a toxic level. 1978, significant studies demonstrate lithium's efficacy in bipolar disorder. Before it was just used as an anti-manic medication. 1980s studies demonstrate effectiveness of carbamazepine in bipolar disorder. Carbamazepine, of course, is another anti-seizure medication. Lithium features. Lithium is the only mood stabilizer without significant anticonvulsant properties. Up to 70% response rate. Lithium has demonstrated effectiveness in reducing suicidality. Less effective in rapid cycling in mixed bipolar states. Full clinical effect may take up to 1 to 2 months. Serum levels guide dosing. And that's one of the reasons I was drawing blood from individuals who were suffering from bipolar disorder. It's excreted through the kidneys, minimal liver-mediated drug-to-drug interactions. Lithium side effects, fine tremors, weight gain, nausea. It's increased thirst and urination. More severe toxicities include coarse tremors, gait instability, vomiting, diarrhea, and confusion. Remember, we said that 70% of the time it works for people. The 30% have the more severe toxicities. Increased risk of toxicity with fluid or salt restrictions, hot weather, sweating, use of anti-inflammatory drugs, ACE inhibitors and angiotensin receptor blockers, and diuretics, anything that builds up in the system that causes diuretics flush the fluid out of your system. All of these things, heavy sweating because of the heat, anti-inflammatory drugs cause the system to burp out as much fluids as possible. This can cause toxicity. It may cause kidney and thyroid dysfunction, so there is a need for regular monitoring of creatinine, BUN, and TSH are necessary. BUN and creatinine are kidney functions, blood urea nitrogen and creatinine. And then TSH is thyroid stimulating hormone. And this is to maintain your kidney and thyroid functions. Females are at much greater risk of lithium-related thyroid dysfunction than males are. Carbamazepine, also known as Tegretol, it's used in acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling in mixed states. It's less effective in bipolar-related depression. Serum levels can be helpful in guiding dosage. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing carbamazepine levels. It induces its own metabolism, so it may need to adjust your dose over several weeks. Side effects: gastrointestinal problems, nausea, constipation, diarrhea, appetite loss. Central nervous system side effects: sedation, dizziness, unsteadiness, and confusion. One of the complaints of people with bipolar disorder. Benign rashes are common. Catastrophic rashes are quite rare. Many possible serious abnormalities in your complete blood count. That's your red blood cells and your white blood cells. It may reduce sodium levels, hyponatremia. Liver function abnormalities are rare but possible. Toxic metabolite, 10,11 carbamazepine epoxide, can create problems via drug-to-drug interactions, valproate, lamotrigine, phenobarbital, independent of carbamazepine levels, and can be checked separately. So if you're taking another anti-seizure medication, you need to be careful. Also, if you're taking a drug for anxiety, that's phenobarbital. You need to be aware of what you're taking. Valproic acid, also known as Depakote, can be dosed rapidly to treat acute mania. It is more active than effective. I'm sorry, it's more effective than lithium in rapid cycling in mixed states. It is used by some to treat aggression and impulsivity and other psychiatric disorders. It is approved for migraine prophylaxis. Serum levels can be helpful in guiding dosing. Commonly used at top or above levels stated for seizure control. Some suggest supplementation with carnitine, selenium, and others to reduce the side effects. The side effects of Depakote: nausea, weight gain, unsteadiness, ataxia, hair loss, and tremors. Liver dysfunction, decreased platelets, that's known as thrombocytopenia. That means your blood doesn't clot as readily. Pancreatitis, rare but potentially serious. Polycystic ovary disease, suggested by some reports. Ammonia levels can be increased, particularly in those rare individuals with genetic metabolic deficits. Drug-to-drug interactions by various mechanisms with numerous other anticonvulsants, aspirin, and others. Lamotrigine, oxcarbazepine, topiramate. These are the newer mood stabilizers. Lamotrigine investigated for mood stabilizing properties after patients on it for seizure disorders report benefits, especially with depression. 1990s, most newer approved anticonvulsants are investigated for mood stabilizing properties. 2003, lamotrigine approved for bipolar 1 maintenance. Lamotrigine, also known as Lamictal, minimally sedating, unlike most other mood stabilizers, so it doesn't make you tired. It appears to be especially effective in treated bipolar depression, but unproven to treat mania. Early use as an anticonvulsant in children raised concerns about potentially life-threatening rash. This is known as Stevens-Johnson syndrome. It's a toxic epidermal necrolysis. Epidermal necrolysis means your skin dies, and that's the rash that they were talking about before. Initiating lamotrigine is done very slowly to decrease rash risk. Valproate greatly increases lamotrigine levels, so you need to be really careful if you're trying to treat them with valproate and lamotrigine. Carbamazepine greatly decreases lamotrigine levels, so you need to be really careful if you're treating them with carbamazepine as well. Oxcarbazepine, trileptal, is used primarily in combination with other mood stabilizers, although efficacy not clearly substantiated. Modified carbamazepine with potentially less side effects and drug-to-drug interactions than carbamazepine. 10 to 11 carbamazepine epoxide, not a metabolite, so it's in higher doses. It's required if you're switching from carbamazepine. Be careful. Topramate, Topamax, research questions its use as a mood stabilizer, although scattered reports suggest possible benefits: weight loss, significant dulling, cognitive dulling, kidney stones, metabolic acidosis. Keppra, efficacy in bipolar disorder unsubstantiated, although scattered reports suggest possible benefit. And I couldn't find Keppra when I looked it up just before this lecture. Minimal drug-to-drug interactions, Zonegran, efficacy in bipolar disorder unsubstantiated, although scattered reports suggest possible benefits. Once again, I couldn't find Zonegran either. Side effects similar to topramate include weight loss. Olanzapine, fluoxetine combination, Symbyax, it's approved to treat bipolar depression. Older antipsychotics, now we're going to talk about the antipsychotics. In 1950, chlorpromazine synthesized as a sedating antihistamine. 1952, chlorpromazine reported to be beneficial in psychosis and mania. This is good news because before 1950, we didn't have anything to treat people with. 1953, first reports of chlorpromazine-associated movement disorders. 1958, haloperidol developed. 1962, long-acting injectable fluphenazine was developed. In 1970, dopamine hypothesis of schizophrenia was suggested. So if you think about schizophrenia and all the conversation that we've had about schizophrenia, now of course the dopamine hypothesis is fairly well established. Well, this wasn't developed until the 1970s. It wasn't accepted all the way through the 1970s until the 1980s. I have a abnormal psychology book that they talk about the dopamine hypothesis as maybe it does work, maybe it does, maybe this is actually the reason that people have schizophrenia, maybe it's not. Really fascinating. So psychology is an evolving um, discipline. In 2005, Katie trial shows positive outcome for perfenazine compared to newer antipsychotics. Older antipsychotics, neuroleptic means seize the neuron, referring to the tendency to cause stiffness and other neurologic symptoms. Early methods of dosing would receive neurolepsis and then back dose down to relieve this effect. As stupid as that sounds, they would give them a toxic level and then they would back it down until they could control it. Major tranquilizers refers to the tendency to sedate, quiet, and even blandness in patients similar to the negative symptoms of schizophrenia. It differentiates from benzodiazepines such as Valium and all the others, which were referred to as minor tranquilizers. So the major tranquilizers are what we gave people who were psychotic. I know this sounds horrible, but this is the way they had to do things. They had no other way of treating people with schizophrenia. They did some pretty nasty things to these people, trying to control their schizophrenia. because they had nothing, no medications were working until the 1950s. Typical traditional conventional antipsychotics differentiates these drugs from newer atypical antipsychotics. Dopamine receptor antagonists highlight strong dopamine activity and tight binding at D2 receptors. And of course, we started giving people D2 binding medications, and this actually relieved their symptoms, but not in everybody. It only relieved the symptoms of a certain percentage. And of course, in the beginning, it was a high percentage, and then it just kept going down, kind of like Prozac doesn't work for everybody. In the beginning, we thought it was this magic medication. Side effects, extrapyramidal symptoms, pyramidal system responsible for voluntary movement. Extrapyramidal system is responsible for involuntary muscle action. It includes dystonias, Parkinsonism, akathisia, and tardive dyskinesia. Acute dystonia, sustained muscular contraction of the neck, eyes, and throat. It generally occurs soon after starting your medication. Akathisia is uncomfortable, continuous motor restlessness. It can occur anytime in treatment, but generally in the first weeks after treatment. Easily misdiagnosed as underlying psychiatric disorder, akathisia. Parkinsonism, tremor, muscle stiffness, slowed movement, drooling, generally occurs beyond 1 week after starting medication. And tardive dyskinesia, spastics, facial distortions, and tongue movements. It may extend to neck, trunk, and extremities. Delayed effect, usually beyond 6 months from starting medication. Risk increases with duration of exposure to antipsychotics. It's known to occur without antipsychotic therapy. It may be permanent, occur in discontinuation, or resolve on its own. It is worsened by medications used to treat other EPS symptoms, extrapyramidal symptoms. Neuroleptic malignant syndrome, pipe-like rigidity, fever, tremor, altered level of consciousness, hypotension, tachycardia, laboratory abnormalities, elevated white count, and creatinine phosphokinase, CPK levels. That has to do with muscle tension. Mortality, 10 to 20% from neuroleptic malignant syndrome. It can occur anytime in any course of treatment, and this is a common cause of death for people suffering from schizophrenia. Anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, mydriasis, which is a term that means dilated pupils. Methods of classification, clinical effect, potency, low potency, chlorpromazine, mesoridazine, thioridazine, medium high sedation, low medium extrapyramidal symptoms, high anticholinergic effects. And of course, when we first give people medications for schizophrenia, we try the low potency stuff first. If it doesn't work, we go to the medium potency stuff second. Perfenazine, loxapine, and melindone has medium sedation, low to medium sedation, high extrapyramidal symptoms, low medium anticholinergic effects, and then the high potency drugs, if we can't get them to respond to anything else. Fluphenazine, trifluoprazine, thiothiazine, haloperidol, and pimozide has medium to low sedation, high extrapyramidal symptoms, low anticholinergic effects. And it's the pyramidal symptoms that we're trying to stay away from. Chlorpromazine, thorazine has a cardiac risk, high weight gain. Fluphenazine, prolixine is a long-acting injection. Haloperidol, also known as Haldol, has a long-acting injection, is available. Loxapine, Loxetane, Mesoridazine serental has cardiac risk. Melindone, Moban, parafenazine, trilafon, pimozide, ORAP has cardiac risk. Thioridazine, Melaril, high cardiac risk. Thiothiazine, Navane, trifluoperazine, stelazine is another. These are the older antipsychotics that we try to stay away from. The newer antipsychotics, clozapine, was developed in 1990. It was introduced in the United States after long delay related to safety concerns. Risperidone, and of course, that's the drug that you're going to hear so much about when you're dealing with people with schizophrenia, with psychotic um, who have psychotic episodes. Risperidone. 1996, olanzapine. 1997, quetiapine. 2000, zypresidone. 2003, aripiprazole. 2004, ADA-APA consensus report on obesity and diabetes in those taking antipsychotics. And this is a real serious problem with people taking antipsychotics. They all cause weight gain, and with the weight gain comes diabetes. So in treating the schizophrenic in treating schizophrenia, we're giving them other problems. Atypical antipsychotics, second generation antipsychotics, are serotonin dopamine antagonists. The mechanism, it adds serotonin activity. It binds more loosely to dopamine receptors. Clozapine, initially rejected as an antipsychotic because of its seemingly reduced dopamine impact and lack of extrapyramidal symptoms. Indication and uses: schizophrenia and other psychotic disorders. This is what are we talking about? We're talking about clozapine. Acute bipolar mania and maintenance, augmentation of antidepressants and mood stabilizers, causes aggression and impulsivity. We're talking about clozapine. Features: it's less risk of extrapyramidal and movement disorders, has a greater effect on negative symptoms of schizophrenia. The negative symptoms are things that are taken away from you. Cautions: greater risk of obesity, diabetes, and lipid abnormalities, and this has been a problem with the newer antipsychotics. Clozapine affects olanzapine, affects quetiapine, risperidone affects ziprasidone, and apiprazole. It requires regular monitoring of metabolic parameters, potential stroke, mortality risk in elderly, the extrapyramidal symptoms, movement disorders, and NMS all can still occur, although much less than typical antipsychotics. So they thought they were doing good. And they were. They actually were keeping people alive a lot longer with the newer antipsychotics. Aproprizole, also known as Abilify, you probably have heard commercials on television about it. It has a unique, complex mechanism. It can be either activating or sedating. Nausea with it is common. Clozapine, Clozaril, most effective antipsychotic. Risk of agranulocytosis, decreased neutrophil white blood cells, agranulocytosis. Neutrophils are the white blood cells that attack bacteria. Lymphocytes are the ones that attack viruses. So if you have agranulocytosis, then bacterial infections can be a problem for you. CBC weekly for 6 months, biweekly for 6 months, then monthly. What are we talking about? We want to make sure that the agranulocytosis is not serious. Multiple other side effects and drug interactions. Levels are reduced by smoking. Olanzapine, and I don't know if you've ever been around people with schizophrenia, they chain smoke. Very common. Why are they chain smoking? The reason they're chain smoking is because tobacco puts dopamine. It increases the dopamine level, and it makes you feel more normal if you have schizophrenia. So these people are tend to be chain smokers, but with clozapine you can't smoke. Olanzapine, Zyprexa, Zydus, significant weight, diabetes, and lipid abnormality risk, and levels, of course, are reduced by smoking. Quetiapine, Seroquel, is approved dose range considered low by many, low extrapyramidal symptom risk. It's used commonly as a sedating agent. Risperidol is most like typical antipsychotics at higher doses. It's available in long-acting injection known as Consta. Zipresidone, Geodon is approved dose range, considered low by many. Initial cardiac concerns appear insignificant for most. Must be taken with fat-containing meal. There you go. Anticholinergics, Cogentin is the least sedating, most commonly used. Quinton, Benadryl, Artane, Simitrel. It's not an anticholinergic. It's used rarely to treat extrapyramidal symptoms. It treats extrapyramidal symptoms, tremors, stiffness, drooling, dystonias. Akathisia may not respond to anticholinergics. Tardive dyskinesia may worsen with anticholinergics. Dry mouth, constipation, blurred vision. Extrapyramidal symptoms thought to be cholinergic dopamine imbalance. Now we're going to talk about the benzodiazepines. These are the anti-anxiety drugs. Librium was developed in 1957. Chlordiazepoxide. 1970s, Valium was developed. That was the number one drug around the world for the longest period of time until it was unseated by Prozac. And then Prozac was unseated by Viagra, as weird as that may seem. So 1970s, Valium was developed, diazepam, top drug selling in the United States. 1986, Xanax, alprazolam was developed. Then it became the top selling drug in the United States. And then, of course, SSRIs replaced some of the chronic benzodiazepine used for anxiety. General characteristics of benzodiazepines differs in action, duration, drug-to-drug interactions, and side effects based on differences in absorption rates, lipid solubility, and metabolism. Indications, uses include anxiety disorder, panic disorder, mania, seizure disorder, phobias, insomnia, alcohol withdrawal, muscle spasms, agitation, catatonia, akathisia. Hospital use, they give it to you as an IV, or they can just shoot it into your muscles, and it will knock you right out. Side effects, sedation, cognitive impairment, anterograde amnesia, so you can't remember what's going on. Respiratory depression at high doses or with alcohol, so you got to be real careful with benzodiazepines. May worsen obstructive sleep apnea symptoms in susceptible individuals. Abuse and dependence, risk of abuse is small in individuals who are not abusing other substances. Withdrawal symptoms and physical dependence are not in themselves problematic if reductions are done gradually to minimize symptoms. Use of longer acting agents to minimize between dose breakthrough and avoiding taken as needed dosing are helpful. Symptoms of withdrawal may represent breakthrough of the underlying anxiety disorder. Needing to increase the dose, tolerance not generally an issue at therapeutic levels. Xanax alprazolam is short to mid length. It lasts in your system for short to mid. Librium stays in your system for a long time. Klonopin, mid to long. It's a serotonergic. In other words, it reduces the serotonin in your system. Transine is a long-acting benzodiazepine. Valium is long-acting. Prosom is mid-acting. Dalmane is long-acting. Ativan is short to mid, has minimal drug-to-drug interactions. Cerax, short to mid again. Restoril is mid, and Halcyon is short. So if we're going to knock you out, we would use Ativan, Cerax, or Halcyon. Or, well, not Xanax. It doesn't, you can't shoot people up with it. It's a drug, it's a pill. Other anxiolytics or hypnotics. Chloral hydrate was first used as a anxiolytic in 1969. I'm sorry, 1869. Ambien was approved in 1992. Zilpidem generic was developed in 2006. Hypnotics medications to induce sleep. Non-benzodiazepine anxiolytics include buspirone and antihistamines. Newer anticonvulsants are used off-label as both anxiolytics and hypnotics, although the efficacy is unproven. Trazodone and some tricyclics antidepressants are used as hypnotics. Neurohypnotics are active at GABA1 receptor, except for Ramilton. Miscellaneous buspirone, subtle anxiolytic and slow response, that's also known as Buspar. Chloral hydrate, Noctec, is a hypnotic, rapid tolerance, toxicity, and overdose. Real careful with this stuff. Chloral hydrate is 3 molecules of alcohol stuck together. So think about that. Antihistamines, hydroxine, pamoate, Vistaril. Benadryl is, of course, the antihistamine that most people take. If you go to the emergency room, they're not going to they will hit you with Benadryl, maybe Vistaril. Anticonvulsants, mildly sedating and calming, Neurontin, Lyrica, and Gabatril. Selective benzodiazepine receptor activity, GABA1, it's hypnotic. Lunesta is a long-term use approval. Sonata is has a short half-life, and of course, Ambien. Melatonin receptor agonist, Rosaram is a melatonin receptor agonist. Stimulants, ADHD drugs. 1956, Ritalin was approved as an ADHD drug. 10% of 10-year-old boys in the United States are on stimulants. 2.5 million children in the United States are on stimulants. Recent FDA warning about increased cardiovascular risk, sudden death for patients on stimulants. Atomoxetine Strattera is a non-stimulant treatment for ADHD. Recent caution about suicidal ideations, rare liver function impairment. Catapress, clonidine, is an antihypertensive alpha-2 agonist. It's used for ADHD, substance withdrawal, Tourette's syndrome, and others. Cylert is rarely used as a stimulant due to liver toxicity. Dexedrine is multiple long-acting form of dexedrine. Insomnia, headache, tremor, exacerbation of tics, nausea, weight loss, blurred vision, overstimulation. Ritalin, same reactions as dextromethorphan. Provigil, non-stimulant. It's poorly understood mechanism of action. It's used for sleepiness related to narcolepsy, obstructive sleep apnea, depression, multiple sclerosis. It's used for ADHD. It's being investigated. Medications for dementia, Cognex, Tacrin. It was approved in 1993. I was still working in medicine when Cognex was approved. Aricept came next, 1996. 1997, generalizability of approval studies were questioned. 2003, Namenda approved for moderate to severe Alzheimer's dementia. 2004, detailed British study questions efficacy of cholinesterase inhibitors. Medications for dementia, general characteristics. The search for a treatment for Alzheimer's dementia is driven by intense human suffering and immense demographic numbers. Studies that support use of these medications generally find subtle benefit or slowing of decline. There is a significant debate about the benefit versus the cost, the money, and the side effects of using these medications. Treatment for behavioral issues in dementia has been complicated by FDA warnings about the risk of using antipsychotics in the elderly. Cholinesterase inhibitors address one theorized mechanism of this complex disease. Donazepam or Aricept, Rimonil, Exelon, Cognex are rarely used due to liver toxicity. Namenda, complex activity via the NMDA glutamate mediated receptor. It may have more broad psychiatric applications. Meds to treat substance abuse. The use of medications in substance abuse treat withdrawal symptoms, benzodiazepines, anticonvulsants, and clonidine. To treat comorbid psychiatric disorders, anxiety and depression are common. You can use SSRIs, mood stabilizers, and benzodiazepines. To prevent relapse, deterrence, craving control. Antabuse is a deterrent. It requires motivated patience. It makes you sick if you drink alcohol. Antabuse. Camprol, craving control, minimal drug-to-drug interactions. Efficacy shown in some studies with more severe alcoholics, although other studies question efficacy. Naltrexone Revia is an opioid antagonist. It has a high response for placebo, causing some to question its study design. Has potential liver toxicity, as practically all of these medications do. Vivitrol injectable naltrexone lasts for 30 days. Buprenorphine, naloxone, Suboxone is a treatment for opioid dependence. It contains both an agonist and an antagonist. Zyban, bupropion is identical to Wellbutrin. It treats nicotine cravings. Several anticonvulsants, topramate, have been used for craving reduction. The use of these drugs are off-label psychiatric uses of antihypertensives. It's off-label. It carries additional potential side effects for their cardiovascular actions. Potential psychiatric benefits have often been discovered while these agents were used for their primary indication of an antihypertensive. Of course, you have to monitor your blood pressure on them. Alpha-2 adrenergic agonists, clonidine, guaifenesin, parazone is used in ADHD, Tourette's syndrome, PTSD. Prazosin found helpful in reducing PTSD-related nightmares. Beta blockers, propranolol, Inderol, is used for akathisia. Lithium-induced tremors, performance anxiety, and aggressive behavior, hyperarousal. Pendolol has been considered for an antidepressant augmentation. Multiple drug-to-drug interactions. You have to avoid it in asthma, diabetics on insulin, certain cardiovascular diseases, calcium channel blockers, diltiazem, verapamil, nimodipine. It may be helpful as additional agents in bipolar maintenance, multiple drug-to-drug interactions, and precautions. And that is the end of that. These are all medications. These are all pharmaceuticals. And I just thought you might like to know some of these drugs. I don't expect you to remember any of this stuff or to remember this stuff. I just want you to be aware of some of the names that are out there as far as antipsychotics, anxiolytics, antidepressants, and some of the other uses that they have for some of these drugs. So when you get into the field, you're going to be hearing these words, these names, these pharmaceuticals, and I just wanted you to be aware that they were there. Okay, that is it. We are done with the lectures for this year. Thank you for taking the class. I always have a good time in this class, and I'll see you in another class.